really reduce your risk for a C-section by declining a non-medically indicated third trimester ultrasound? The answer is yes. Ultrasounds are done in pregnancy to identify a few different things. First, there's a dating ultrasound that many people get in the very beginning of pregnancy. This is an ultrasound to identify how big your baby is, and that measurement can help us identify how old they are and how far along you are in your pregnancy. The benefit of getting this ultrasound is that we can be really sure on your dates. Some people have irregular cycles, like me. I remember getting that ultrasound and then being told I wasn't as far along as I thought that I was. And I'm glad that I did that because that made my due date much more accurate. So when I was actually due, I would have thought that I was way overdue, and then maybe I would have had an unnecessary induction. And this one, like all ultrasounds, are optional. The one that ACOG recommends is the anatomy ultrasound that's done between 18 and 22 weeks, so right in the middle of pregnancy. Typically, it's done around 20 weeks, and this is an ultrasound to make sure the cord is inserted into the placenta in a good place, that the placenta is attached to the uterus in a good place, and that the baby has all their parts. After that, they offer the routine growth ultrasound, and we'll talk even more about that here in a minute. And then the last ultrasound that's typically offered is around 36 weeks, where they confirm that the baby's head is down and that the fluid looks good. According to evidence-based birth, declining non-medically indicated ultrasounds, meaning ultrasounds that occur for no specific reason, no medical indication, they're just routine at wherever practice you're at, in the third trimester, reduces your risk for cesarean by avoiding big baby bias. So we have research that illustrates that if your provider thinks your baby is big, they're more likely to want to schedule a cesarean to give you a shorter trial of labor or a shorter pushing phase. So it's not actually your baby being big that increases your risk for C-section, it's your provider thinking your baby is big. And one way that we can reduce the risk of your provider thinking your baby is big is by declining a growth ultrasound in the third trimester. Now, I want to be clear, I'm not telling any of you to decline this ultrasound. If it feels like the right choice for you, please go ahead, get the ultrasound. But it's important that you understand what the risks and benefits are of that intervention so that you can make an informed choice that feels right for you. A medical indication to get a growth ultrasound in the third trimester might be that your fundal height is looking really, really small and we're worried about baby's growth. Or there are maybe other signs that your baby isn't thriving or doing well. But if everything is going normally and well, it actually isn't even recommended by ACOG or the American College of Obstetricians and Gynecologists to do routine, non-medically indicated growth ultrasounds. Those should be reserved for people who have some kind of medical indication. But it is very common across hospitals all around the world to offer a routine 32-week-ish growth ultrasound. Why? One, we can bill for it, and hospitals are businesses that want to make money, so that makes sense. And also in the Western medical model, there's this idea that when we have more data, we have more control. We can control birth better when we get more data. Because remember, in this philosophy, we're treating birth like it is an issue, like pregnancy and birth is a medical condition, rather than an expression of health and a normal physiologic experience. So there are many models of care that won't even offer a 32-week growth ultrasound unless you show signs that you need it. There are other places that will offer it routinely. It's important to know that even if something is presented to you as the norm or something that's required, you always have the right to decline if you don't want to. You also have the right to ask for a second opinion and ask questions. So, growth ultrasounds in the third trimester can increase the likelihood of your baby being labeled as a big baby. And if your baby is labeled as a big baby, you're more likely, we have seen this in research, to get a C-section because of big baby bias. So I'm going to tell you a couple of stories to kind of illustrate what that looks like. First story, I have a friend who was pushing her baby for a long time. She was pushing. A couple hours went by and not a lot of progress was being made. It turns out her baby's head was tilted a little bit to the side, which is called asynclitic. If they had looked for that and tried to figure it out, we may have been able to support adjusting the baby through position changes. But instead, she was on her back, just pushing without any position change. And eventually, the doctor looked at her chart and said, well, it says in here that your baby is supposed to be pretty big. So the reason why your baby's not progressing, not coming out, is because your baby's too big for your pelvis, so we're going to have to give you a cesarean. And unfortunately, that cesarean was very complicated because the baby was so low and really, truly like about to come out. And and it'll make it probably unsafe for her to be able to have a vaginal birth after cesarean in the future, which is just really, really sad. And it turns out her baby was an average size, around 7.5 pounds. So it was not the fact that the baby was big and wouldn't fit through her pelvis. It was because the baby wasn't in a great position and she was on her back pushing the whole time. If they didn't think that her baby was big, they likely would have tried other things or maybe offered forceps or vacuum or alternatives to a C-section. I have another friend whose baby was born with the head a little bit extended. So typically babies will tuck their chin when they're coming through. This baby had her head extended a little bit like this. She was at a home birth. The baby started to show a little bit of meconium after pushing for a while. Meconium is when the baby has a poop in utero, and sometimes that means that the baby isn't doing so well, or they're starting to get kind of stressed. So the mom transferred to the hospital, and the doctor assessed the situation and said, I think we need to give you a C-section. Let's prep the OR. And the midwife who transferred with them said, can you please do forceps or vacuum? Can we explore alternatives? And he said, well, how big is the baby? And the mom did get a growth ultrasound and her baby was measuring big, but she didn't want to tell the doctor that. So she said 8, and the doctor said 8 what? And she said just 8. And the midwife was like, yep, just 8. And then the doctor said, okay, if the baby is just 8, then I'll use the vacuum. And he used the vacuum. It popped off once, it popped off twice. And so this was the last chance with the vacuum. And he coached the mom to push really hard and he pulled and the baby came out. Yay! And she got to have vaginal birth and her baby is perfect. But if he thought her baby was big, he wouldn't have even given her that opportunity and she would have had a cesarean. The reason why he didn't have access to her growth chart was because she transferred from a home birth, so he didn't have access to that. But if he did, he probably wouldn't have even given her that chance. So evidence-based birth says this big baby diagnosis actually affects a lot of families. In one study in the US, 2 in 3 families were told that their babies were too big. And 1 in 3 families had the provider discuss cesarean for that reason. But the actual number of babies who meet the definition of a big baby is actually quite lower because ultrasounds are only accurate at identifying fetal weight about 50% of the time. So that means you can perform an ultrasound and say, wow, your baby's in the 90th percentile. They're huge. They're, for example, 9 pounds. And then that baby can be born an average weight and not be big at all. Evidence-based birth says only 1 out of every 10 babies are born above the general cutoff for a big baby, which is about 4,000 grams or 8 pounds, 13 ounces. So what do you do if for some reason your provider wants to send you to get your placenta looked at? If the placenta was a little lower or there's some medical reason to look and see what's going on in there, but you also don't want the growth ultrasound? Because there is medical indication for a growth ultrasound, meaning we should look at the baby's growth. And sometimes we want to do an ultrasound that doesn't have anything to do with growth. So if you are not wanting a growth ultrasound, but there's a medical indication to look and maybe check on something else, like let's say it's your placenta, you can say, I consent to measure it. You can say, I consent to this ultrasound specifically to look at the placenta. I consent to measuring the placenta. I decline the growth ultrasound, and make that clear to the ultrasound tech that you decline them taking those measurements. You can also talk to your provider and tell them, it's really important to me that I decline the growth ultrasound. This is just an important decision. You can also talk to your provider and say, I want to do everything I can to reduce my risk for C-section. And I know declining the growth ultrasound is an evidence-based way to do that. So I know we want to look at my placenta. Can we do that in a way where we're not taking measurements for the baby's growth? Because that's something that I don't want. So in summary, a routine late pregnancy ultrasound may just seem like we're just checking and seeing how things are going. But evidence-based birth says that if there's no medical indication to do that ultrasound, it can increase your likelihood for having a cesarean by creating false concern about the baby's size. Since big baby diagnoses are wrong half the time, and only 1 in 10 babies are born over the big baby cutoff, many families may be counseled around induction or cesarean based on a suspicion that turns out not to be true. My name is Victoria Tippins. I'm a childbirth educator, mother of 3, student midwife, and birth worker of 15 years. And I created the Peaceful Birth Method, which is a 5-step process to support parents in feeling confident and prepared for birth. My private coaching clients achieve outcomes 9 times better than the national average. And I share my 5-step foundational framework that they use to get these results in my free Peaceful Birth Academy. Just click the link below and I'll see you over there. If you're already in the Academy, book a free birth breakthrough session with me at the link below. And on that call, I'll clarify the steps needed for you to go into birth feeling confident and prepared and explore how I can support you in my coaching program. You've got this.